Good thought. They don't have a car. Or let me say actually, let me back up. Who has not seen the socio-ecological model? Might be rushing. Neil, okay. Yeah, the other people? Okay. Look it up after today. There's an article on the CDC that just has they draw theirs like in ovals this way. It is something that is extremely important to know. I think it's like a very foundational tool because it really helps us to think about where factors fall. But I would consider CAR actually in this environmental level. Can anyone help me out? Because I'm having a brain fart. It's organizational, and what is the other term that we usually use? Community? Is it community? Can you look it up for me, Brandon?
Yeah.
Because I don't think it's environment, but CAR usually would fall in this third category, okay? Because CAR is not just, it's not just about the individual person. It's about the person having the finances, which is probably related to their job, right? Or it could be even an interpersonal level where they don't have access to someone else who shares a car with them or who can support them and help them out with a car, right? So usually it'll fall in one of those two categories. Yeah, great, Jeff. Living in working conditions. Oh, I like that. I've not heard that version. Living in working conditions, or what we're calling environment. But yeah, that's a good one too. Okay.
I'm also seeing, yeah, like institutional and then community.
Yeah, so we said living and working or community or environment. Yeah. Okay, good. Okay. What are individual factors? Let's go back to that one. Individual factors that impact someone's ability to have health problems. Health problems. Yeah.
Residency. Like if they're not a citizen in the United States.
Yeah, I'd actually maybe put that at a different level. What do you all think? Maybe. And sometimes they fit in multiple levels, but I think that might be more structural or environment. Yeah. Grace.
I was gonna say like maybe they can't read or they don't have the means.
So language accessibility?
Yeah.
Okay, yeah. Language accessibility. It's probably gonna be individual, maybe interpersonal, maybe environmental if they didn't have access to school. Yeah, so you can follow different places. Yeah, Michelle. Tobacco use, yeah, that might be an individual level. I would put income usually at environment or structural. So a lot of times individuals also attitudes and beliefs, right? What we bring into a conversation that we don't even know, right? Like you can see a person, you can know their name, but you don't know what their attitudes are about health insurance. You don't know what preconceived beliefs they bring into that conversation, what prior experiences they've had. All of that is impacting the future of your conversation. Anything else for individual? Okay. What do you all think could be interpersonally affecting? And hopefully this list is giving you some ideas. What is interpersonal? And interpersonal refers to relationships with other people, somewhere between environment and individual. So like interacting with another person. That's usually what we put in this category. Yeah, domestic violence. Marital status, yeah, family structure.
I'd like to stick at like maybe.
Yeah, like, yeah. Yeah, and I think you could argue that that could also go other places as well. But yeah, that's a good one. And if, like, at what age do you become a parent, and has that impacted you with things? Okay. Or
If you have negative experiences.
yeah, negative experiences with previous providers, absolutely. And then I would also bring that back into individual because now that's an attitude that you have because of prior experiences.
Like level of education. I mean, I think that could also be like environment, in terms of like access, but like just like in terms of like how educated somebody.
Yeah. Yeah. Can I tweak that one maybe? Maybe also the level of education that your parents or your family or people around you have about health insurance, right? That's gonna also impact your level. Okay. Others? environment or living and working conditions. I think this one's gonna encompass a lot of things. So what do we have here? Yes. Again, we're thinking about factors that influence access or use of healthcare.
Or like job,
Job and
economic status.
absolutely. Extremely important. We know that because we have shown you in every single question that we need to ask that. We need to know that.
Maybe if they live somewhere like.
Yeah, yeah, if they live somewhere where it's rural, because that's a great example of when maybe they have healthcare coverage, but they're just unable to use it. Because they don't have the right provider around.
No, access to food options, I think they live.
Yeah, if they live in a food desert or a food apartheid, exactly. What else?
Education.
Yeah, education. Tell me more about lifestyle.
Also, like, it also relates to work, like how long their work hours and work. When they come back home, are they able to themselves, like they have a dependency?
Yeah. And such a good point, because when we are working with people in the clinic, we're a nighttime clinic. I think we've given you very little information about what our clinic looks like. We're gonna get there, but we're a nighttime clinic. We only operate on Wednesdays, and people will drive a far distance to get to see us sometimes. And that's something you have to consider is, did someone work an entire day and then come to see us? Did they work the night shift? Did they have to move their schedule around? Do they need to take their children home soon, right? We're actually the last people to see people in their appointments, so they've been there for 2-3 hours and they're just tired. And that's another thing that you need to kind of keep in mind is like, how long has this person been here? What is their day look like beforehand? What is it gonna look like after? I think it's also important to consider these things, not just in the exact moment that you're working with them, but also in situations that I think all of us have been in, where a client has said, I just cannot do this today. I don't think I want to do this tomorrow, or maybe even in a month. I don't know if I want to apply healthcare coverage. Thank you for what you told me, but I don't know if I'm ready for this. And I think some part of us will probably feel like, no, we want to help you get health insurance, right? But then we can think back to all of these determinants that are kind of contributing to the decision that that person has. And I think that can also help us to understand what are some ways, even if we're not helping them apply to a plan tomorrow. Structurally, we're looking at all of our policies, what Medicaid looks like, what Medicare looks like, what the ACA looks like. We're looking even at social norms in that category too. A social norm could be that a family might be eligible for Medicaid, but feels like having Medicaid is not a good thing. It may be, imply something about their financial status and they don't want to have that implication. So maybe that social norm means that they don't want to have Medicaid. That could be a social norm. Any other things for structural? And I think we didn't include too much about providers. Someone said something about like past experiences of providers, but even provider availability, that could fall under that environmental living, working conditions. And we talked about being rural. What else? Zip code and geography. I think we briefly talked about this, but this would probably fall under environment. Transportation. I didn't hear anyone say transportation. How does transportation affect access to health care coverage? Yeah. Can't see your doctor. Okay, yeah, that's one.
I was gonna say maybe under structural, like, they don't technically qualify for like Medicaid or even a tax credit, but they still like can't really afford like health insurance. It's just with like their other.
Yeah,
costs.
yeah, that's a great one too. It's just they fall kind of in a gap. Yeah. Or maybe like immigrant laws and policies that we have. And we talked about it's really complicated and we can hopefully go into more depth today, but the structure of how we've kind of decided who should have healthcare coverage in this country is based on your citizenship status or your residency status. Stress is also something that I don't think anyone mentioned, but can fall under individual. It can fall under living environment. Which one other I was gonna say? Oh, and transportation. The other thing about transportation is just getting to our clinic sometimes. The big ones, right? So for some of our patients, their conversation that they have with us today was the first time that someone reached out to them and offered to support them with this really complicated task. And if they can't even get to us in the clinic, then that's already a barrier that we're facing. And Marina, I think honestly, our champion, our front soldier on this endeavor, the GCC has taken on working to improve transportation access for our patients. And so we're actually working to provide vouchers for patients to get to clinic. It's a clinic-wide initiative. It helps every single division, obviously, but something that we feel is
Hopefully
really
you guys
important.
could be part of it in the future.
Yeah. Please pray for us.
Yeah.
Pray for that to happen before, or like send good vibes and that'll happen before May.
Please.
Okay, and then obviously, this chart shows that there's a lot of health outcomes to all of these factors, but we know there's also outcomes related to access. Okay. Alrighty, so now let's shift a tiny bit and talk about cultural humility and cultural competency. The modules will talk all about cultural competency, so I won't go into that. But can anyone give us a synopsis about cultural competency, what it is? Yeah, Carson.
It's your understanding. that people have different cultural backgrounds. And understanding where that comes from and how that fits in the healthcare system, how maybe they see healthcare.
Yeah.
And we just have to realize that despite that difference, like we're here to help them get coverage and just try to direct them in the path that like will fit there.
Exactly, yeah. I almost think you described humility a little bit more than cultural competency, but excellent, I like that a lot. Do you have something to add, Nikki?
Oh, I was just gonna say, kind of like understand, I mean, it was kind of piggybacking off what he was saying, like, how someone's backgrounds and cultural beliefs will kind of like influence how they wanna perceive like medical care, like what route they wanna take.
And when we say culture, what do we mean?
Like attitudes and beliefs.
Yeah, attitudes and beliefs that are likely passed on by the people you're surrounded by, your community, your family. And I just bring this up because culture is not just about race and ethnicity, right? It's not just about language you speak, it's about so much more. So cultural competency is acknowledging that every single person comes with these attitudes and beliefs, and that we will never have, actually cultural competency is different, but I'm explaining cultural humility. Cultural humility is this idea that everyone comes with these backgrounds, these attitudes and beliefs, and that we will never be able to be fully competent, fully knowledgeable on every attitude, every belief that each person will bring. Right? Even if you are looking at race and ethnicity, a person of one race or ethnicity does not necessarily share the same culture as another person. Race and ethnicity, right? We all have our different culture, our different attitudes that we're bringing in. And so humility means that we are bringing in our attitudes, or we are not affecting the conversation and bringing our own attitudes into that situation. We're acknowledging that there's a lot to learn from our patients. And that they're bringing all these factors that are influencing their ultimate decisions. Take a few minutes, and I think there's a prompt for you all to write about cultural humility. It's on the training module 4, maybe 3, I don't know. Training session 4-3. What time is it? I think instead of writing, let's watch this video. Yeah. I mean, yeah, we'll watch the video and then Okay, we'll stop there. But those are the three tenets, and Tervalon and Murray Garcia coined the term cultural humility after there was a lot of push for cultural competency. And if you want to read their work, they are wonderful scholars. But you can see right there, so it's lifelong learning, addressing power imbalances, and then institutional accountability. And I'll actually let Verena talk a little bit more about power imbalances and how we kind of hold a position of power in a way in our patient interactions. And so it's really important that we are aware of that and take measures to mitigate those power imbalances so that we are having a more open, equal conversation with our clients. They're very simple things, including sitting down next to your client instead of standing up over them, right? This is a power imbalance. Hi, how are you? This is a power imbalance. We talk about all the time how you should not stand over your patients. You should always take a seat. They're simple things, right? But it's all about us continuing to hold each other accountable to these practices. And we think it's so important to talk about that in this training, and then you'll continue to learn about it as we keep going. You're going to develop this skill. Okay. Yeah. I don't know what's that. Is this the right place?
Yeah, so like Zara was saying, all of that stuff is going to build onto this next conversation based on Module 7, talking more specifically about culture and language. So this is, again, an especially relevant discussion for us because the patient population that we work with, they come from a lot of different backgrounds. You guys are going to get to meet a lot of different unique people with different cultures, upbringings, experiences. And you need to be able to approach those conversations with a very open-minded perspective. And that's where the whole cultural humility part comes in. Learning from the patient, hearing, their past maybe negative experiences with health coverage, things like that, that you really want to get an idea of how you can best support them and make sure that you're not playing a part in any sort of like, what's the word? Yeah, negative element, or what's the word whenever it's like from a physician specifically, like with the cultural, like any lack of cultural humility, I guess is what I'll say. We don't want to be contributing to that in any way. So that's what we're going to talk about. And there are definitely best practices that we can use whenever we're in clinic. The first one we'll talk about is interpretation. So we have a bunch of different languages that we deal with, but one of the most common ones is Spanish, is what you'll see. We have a few other languages offered in clinic. There's always usually a Mandarin interpreter. And then I've also seen some others, but it's, what was it? Yeah.
They'll know who's coming into the clinic at that time, they'll call it.
Right. Yeah. And there are definitely there's a specific way we want to work with interpretation to make the experience as seamless as possible for the patient so that they don't feel like it's like a fragmented conversation. We still want it to feel like we're talking with the patient and that the interpreter is there as like a guide to, help us communicate, but not that they don't know who to talk to or make it confusing, So on this diagram on the right, you can kind of see how we're supposed to sit with the patient whenever we have an interpreter in the room. So this first point is really important. You want to be talking to the client, maintaining eye contact with them, not talking to the interpreter. So this is where it can quickly become like the patient feels like they're not having a direct conversation with anyone really, that they're just like, me and the interpreter are talking about all of the stuff that we're discussing, but like they don't feel like they're the actual main focus of that conversation. That can be a really easy thing to happen if you're not sitting in front of the client, maintaining eye contact with them, directing your questions to them and not the interpreter. And yeah, making sure that you're still maintaining the conversation with them and not the interpreter. So I talked about the second point, speak directly to the client. It should never be, hey, can you ask the patient what their income is? You are looking at the patient, you're saying, can you tell me about your household income? Things like that. Okay. The question is directed to the client. And yeah, this is, the last point. Just don't say, please tell her, or I'd like to know, just talk to the patient directly. The other thing is, there was something I was just thinking of that should be here. Yeah, go ahead.
So that second bullet where we say pause at natural points, obviously our interpreters are wonderful,
Mhm.
but they cannot interpret a 2-minute monologue that we start going on. So just pause at natural points, and this will get more comfortable as you work with interpretation, but it should really be no more than a sentence. And honestly, I've learned that it's best to pause more and let the interpreter interpret that portion. Both Megan and I, you don't know Spanish.
No,
Yeah.
my Spanish is horrible, so I really rely on these interpreters.
Understand Spanish, and some people also speak with our patients in Spanish. But I've noticed that if you talk for a few, 2-3 sentences, and you ask, like, the interpreter starts to interpret it back, they will often miss points. And we know why we said that question, but they have no idea, right? Because they're just there in a conversation, they're not a counselor. So then I'll have to repeat the question. So I think it's just better to pause more so that we can really get across what we're saying.
That reminded me what I was thinking of. So pausing at certain points is also very important. It's also important to remember that the interpreter might not follow these rules as to the T as you are. And it's okay to have a relationship with them where you're like, hey, can we make sure that like I get the direct interpretation from the patient instead of you guys having a conversation like on the side? Because sometimes I've been in situations with an interpreter where the patient will respond to the question that I ask, and then they needed to make a clarifying point, so they'll like ask another question real fast, and then they'll never tell me what the patient initially said. It's okay to say, hey, can you repeat back to me what they just said so that I'm completely in the loop. So you guys shouldn't be afraid to do that, because the interpreters sometimes they just forget, it's not like any harm done on their part, as long as you make sure that you clarify and get all of the information that you need. So yeah.
And you can set that expectation ahead of time.
Exactly, yes.
I think we talked about that. Can you talk about that interpreter?
Yes. This note in the blue box, interpreter is referring to people that are interpreting like a verbal conversation. Translator is referring to written words. So we shouldn't use the word translator when we're talking about shack interpreting. And they refer to themselves too as shack interpretation. So that's just a separate term to keep in mind. Yeah. Yes, so this is what Zara was talking about, where it's really important to set expectations before you go into the patient interaction with the interpreter. So you definitely want to brief the interpreter on what the conversation is about to look like outside of the room. This doesn't mean like a full like long explanation, but a lot of times it's like, hey, I'm about to go into this room. We're talking about UNC financial assistance. I'm just going to walk them through the eligibility and document requirements, things like that. Just so that the interpreter doesn't go in blind, not knowing what to expect. And this applies to phone conversations as well. If I have an interpreter on the phone, I'm not just going to have them hop on that phone call usually and just like start interpreting. I'm usually like, hey, this is the conversation I'm about to have. Can you help me? Communicate with this patient?
Good time to establish. I would like you to direct everything I say in first person. I'm going to be directly facing the client. You can just situate yourself.
Yes.
You can establish those expectations for the conversation, because not everyone uses interpreting the way we do.
Yeah.
To have really delicate
conversations. Yeah, that's a really good point too. Yes, that's the third point that we've mentioned several times. And then, like I said before, all of these things apply for a phone conversation as well. There probably will be multiple instances where you need an interpreter on the phone. And you shouldn't have them go in blind to those conversations. You should set out expectations beforehand. And definitely, if you have any concerns about an interpreting interaction, see your coordinator. And if you have any questions about navigating the interpreting situation in your first couple encounters, this is of course something that your coordinator is going to support you with. Do you guys have any questions about working with interpretation? Oh, yeah. Oh, yeah. Can we demo in person what we mean by this? Yeah, go ahead.
If we know, like, how Spanish ourselves.
You absolutely can do that. Yes.
I'd honestly encourage that, yeah.
Mm-hmm.
We're actually thinking about doing some kind of, maybe with other people to practice that, so you can feel comfortable. At least if you do something in Spanish, you practicing that, when people doing it, because that's already gonna establish your plan. Okay, we can continue the rest of the course. You can do that much, you're already, connecting with that person.
Yeah. Or like knowing at least like in Spanish, at least for me, it was helpful to for me to know like, oh, give me 1 second while I go grab an interpreter if I didn't realize initially that I would need one, just so they don't see me like just like leaving the room, coming back. Like knowing just some helpful phrases is definitely good. But yeah, definitely it's not an explicit like expectation that we have. Yeah. Yeah, that'd be cool.
But we're thinking about getting our interpreters.
Yeah. But
What do you want who?
Let's see. Okay. So I'll have it. You'll be the client.
I'm interpreting, okay.
You're interpreting. I'm the volunteer. Okay.
And just for the sake of this conversation, we are interpreting in English to English. Okay.
Oh, we're doing an interaction. Okay. Well, no, I was going to show like what we meant by loss of connection. We could do that. But what I was going to demo first was just what we're showing with this diagram, okay, is that the interpreter is right there. I'm still sitting directly across from the client. You're my client, right? Yeah. I'm still sitting directly across, maintaining eye contact this way, okay? I'm very much minimizing loss of connection, okay? Hi, can you ask her what her household size is?
Sure. What's your household?
I'm feeling a loss of connection. Exactly. Okay, so it's like this, okay, and then we communicate as a team, all right?
And then the other thing that you want to avoid, so ask me that question,
Can you ask the
or actually, you asked him in directly.
hi, what's your household size? One.
Oh, and then I'm sorry, you didn't understand that.
Oh, I didn't.
We're really bad at this, okay, go ahead.
What is your household size?
She wants to know what your household size is.
One.
She said her household is one.
Bad, everything about what's happening really bad, okay? Let's now do a good example. What is your household size?
What is your household size?
One.
One.
See, it's exact, not he said, she said, okay?
Thank you.
I don't know if that was helpful at all, but
there we go.
Okay, we stress this though, because like we said, we love our interpretation group. They are students. They are usually in their capstone or like doing a Spanish minor. So they're not professional interpreters. They are obviously qualified to do what they're doing, but they're not professional interpreters. So, and they're coming to clinic not as often as maybe even we are, because their spots are really limited. So it might be their first and last 2 months. And it's always a good idea to kind of reestablish those expectations. And it's better to do it up front than have to have a conversation in the middle where you're like, I'm so sorry, I need to stop really quickly.
Yeah.
I would prefer if you interrupted directly as the client is saying, right? It's better to just do it before you go into it.
Exactly. Yeah. Okay.
Do you have any questions on interpretation?
Anything at all?
How to how to go get an interpreter and what that looks like.
Mhm.
A lot of our training is gonna continue in the clinic, just FYI.
A lot. Yeah. In person is like where you'll learn. And it's also where all of this will get like solidified, because things are hard to remember until you see them in practice. So I think it'll help with that as well. This was module 8. Module 8 talked about patients with disabilities. And the way that was defined was a person who has a physical and or mental impairment that substantially limits one or more major life activities. The final rule that's being referred to here is referring to the prohibiting discrimination against disabled individuals, requiring reasonable and appropriate accommodation for disabled consumers, and ensuring equal services / treatments are offered to them. And that was as part of the, do you remember what that was called? That wasn't the,
Not in the ACA.
no.
This refers to like,
The final rule is like a specific name for like something that I can't remember.
yeah, I don't remember what it is, but it refers to like, we cannot, we have to give large print summary of benefits and coverage if that's what someone requires. Or we need to give a ramp for someone to get into our clinic to be able to speak to us. Or we need to be able to provide something in Braille if someone requests that to us. Like those are the requirements that this covers.
Right, yeah. I can't remember what specific like law set that out, but yes, this is of course something to keep in mind. It is important to also differentiate between like this general term about disabilities and social security disability, because someone could have a physical or mental impairment that substantially limits one or more major life activities, and that not necessarily be recognized by social security. So I've definitely been in situations where someone suspects that they might have a qualifying disability, and I like would refer to them to the Department of Social Services to help them with that application, because that's not only beneficial for applying for health coverage, that's beneficial for like a lot of other benefits as well. So yeah, that differentiation is important. Social security disability is something you have to apply for separately.
Final rule is part of the ADA. Title II.
Okay, okay. Yeah. All right. Do you think we have time for this? I think with the financial assistance, we might not.
Yeah.
Okay.
But I think we could take a break.
Yeah, we can do a 5-minute break.
Before we break, does anyone have any questions? That was a lot of like, how do we want to be as an organization, right? Not as much knowledge of what we need to know as a counselor, but it is so important because we really pride ourselves on our PCC volunteers, and we think we're a wonderful group, a very respectful group, very patient-focused group, so we have obviously uphold that.
Mhm. And you made a good point too earlier about how our conversations with patients do look a little bit different than like the other branches of SHAC. We're talking a lot of times about like personal information that, you know, we need in order to help them explore health coverage options. And sometimes that means that this stuff about like humility, understanding, like coming in with a very open perspective and everything, that's where it becomes really, really, really important. So yeah. Okay, we'll break for a bit.
Refresh, we're almost there, y'all. You're almost there. Yeah.
Dude, I feel so bad.
Individually copy each one, and then my printer doesn't do that. And then I like. Oh, nice to meet you, Leslie. Okay, we will send you this. Thank you for coming. Bye. She's not a student, but she, oh.
And or are we just gonna have a lot of later? No, I'm getting nervous. Thank you. We're basically
You're very
after
excited.
six hours. That's true. Jay. Oh, we still. From Europe.
Here, you're America.
Oh, yeah, yeah. Do you want me to just, if you want to just tap me in?
Yeah. All right. You guys ready to get back in? Are we missing anyone? Oh, okay. Let's give it like 5 seconds. Oh, okay. Okay. Yeah, yeah. All right. So now we're shifting over from all of that content that is like generally, for a certified application counselor needs to be aware of. And then there's the stuff that SHAC volunteers need to be aware of. So these are going to be like clinic specific information and stuff that's relevant to our local community population that we work with. So that's what we're going to be discussing in this last section of training, which is, yeah, the last part. Okay. So first thing is the clinics that we offer. We operate out of actually 4 main clinics. These are 3 of them, but we also have a virtual clinic. So I'll go through each of these individually. There's the medical clinic and then the dental clinic. Both of these operate on Wednesday nights. Med clinic is usually lasts a little bit longer. It says 6 p.m. to 10 p.m. here, which we do allow volunteers to like leave at that time. But like oftentimes you might like still be talking to a patient or something like that, just like full transparency. And then dental clinic usually ends a little bit earlier. That's because their volume is slightly lower a lot of the time. And yeah, that's usually just how it works. They're just a little bit more efficient. Med clinic it's pretty hectic, to be frank. It's like there's a lot going on, things are moving around pretty quickly. It used to be even more so, but now we've been like pretty integrated into the clinic flow in a good way. It used to be just like kind of impromptu conversations with patients like in the lobby. Now we're like part of the care team, I guess, like after the med team talks to them. And then there's like another branch called social needs that screens them for like broader social concerns. Then we come in if they expressed health coverage needs. So it is more less hectic than it used to be, but still it's much busier, a lot more going on, but there's so much to learn and you see a lot of different types of situations here. So you can see that at Med Clinic, the types of things we deal with are all the things we've talked about today. So Medicaid, Medicare, definitely Marketplace as well. And then UNC financial assistance, which we're going to get into. And then there's also a medication assistance program. That's its own separate branch of SHAC that we work with frequently for patients that need it. Yes, that's true. Yeah. So we can refer people to the dental clinic when we're at med, and then at dental clinic, we can refer people to the medical clinic as well. So all of this is like within the larger SHAC umbrella, and we want to make sure that people at SHAC are utilizing the SHAC resources to like maximum ability. So yeah, dental clinic, same, we'll be dealing with the same type of stuff as medical clinic minus the medication assistance since they're like not physically there. But if we see that it's something they might need, we can still connect them with that. Dental clinic, I will say, I think the patient population is a little bit different in the sense that I notice at dental clinic, there's a lot of people that maybe already have insurance or something. But because dental care is so hard to receive at a low cost, even when you do have an insurance plan, you'll meet a lot of people that, just are trying to address specifically dental concerns. And so the conversations with them would definitely look a bit different depending on what you think might help them meet those needs. So we'll talk more about that in a bit. CEF, this is like anything healthcare related. This one doesn't operate at night. It's going to be Tuesdays, 10 a.m. to 12 p.m. You'd be working with Megan at CEF. And this is at and CEF stands for the Community Empowerment Fund. Sorry, I should have opened with that. I don't know if any of you have heard about the Community Empowerment Fund before, but they do a lot of different things to help people connect with various community resources, and we're there to counsel on health coverage whenever we're needed. So yeah, this one's more slower paced because you'll be dealing with one patient at a time. Well, obviously you're always dealing with one patient at a time, but there's only one patient there to see us at a time at CEF. So it's definitely much easier. I'd say CEF and dental, we usually say, are a good starting place if you're a little bit intimidated by everything and like want to like kind of ease into it. They're definitely slower clinics, but you could easily start off at med clinic your first shift and be perfectly fine because you'll be with us like every step of the way, and we'll definitely get you acclimated to the environment and everything. But yeah, do you guys have any questions about our clinics? Anything? Oh, really quickly too, what isn't mentioned here is our virtual clinic, which Dorian runs. That's where he had to leave to because he has that open bi-weekly at 2 p.m. Right on Saturdays. And right now it's like by appointment. So as needed, we'll schedule someone for that time. But yeah, if no one ends up signing up for virtual clinic, then yeah, it's just like based on appointment. And you guys are able to sign up for that as well and help him out. That's like one volunteer we open that to every week. So that's also another really, really great way to just see one conversation all the way through. And it's like a good introduction into what we do. GAC, yes.
Oh, there was.
Oh, thank you, Annika. This is what I just said. Yep, for the virtual clinic. And then GAC clinic, the gender affirming care clinic. This is also held in a virtual format on Wednesday night. So it's operating the same time as med and dental, but we come on in a virtual format to help out. And this one is a little bit more targeted to more experienced volunteers because there isn't necessarily going to be a coordinator there every night. The coordinator is going to be accessible via like phone or whatever. But the volunteer that signs up for GAC clinic will mainly be leading that independently. So that's something you guys could think about in the future as well. And that could be dealing with pretty much anything also.
So we are really thrilled to see how large GCC has grown over the years. I think our numbers have increased every single year in a good way, and we have also increased our capacity in clinic. We've added spots, but even though we're increasing the amount of opportunities that are available, including our virtual clinics, there is still a challenge for people to find spots. And then we're welcoming 18 more people now in the spring. You all are the lucky last group that we're
Yes.
doing that for, because we think we're kind of going to be at capacity as an organization. We'll kind of have to be very selective moving forward about who we open up the opportunity to. And I say this because I think the virtual clinics get underutilized. I think that there is so much that you can learn, so much that you can support patients with virtually. It is a completely untapped environment where we could, even if it's going really well and we actually need more capacity, we could expand the amount of options we have for virtual clinic. You can be in the library, in a private room, you can be at your house, you can be anywhere and still be able to participate with GCC.
Yeah.
So I just really, I don't think our current volunteers are utilizing it enough. I want you all to know that it is a wide open ballgame.
And it's also great because you like really get to sit there and see the whole conversation like through for as long as is needed, which again, like I said, when we're physically at clinic, we're dealing with a lot of different cases at the same time, like all of the teams working together. But this is like very much just one, it's a very focused conversation. So again, it's just like a slower pace. You'll really be able to interact with that patient for as long as needed, maybe get them through an entire application. So yeah, definitely what Zara said, don't underutilize that as an opportunity. Yeah. And there's something else I was going to say, but I forget. Hopefully it'll come to me. So now we're going to talk about something called UNC Financial Assistance. The reason it's in this part of the presentation is because this is something that's relevant to the population that we work with, because it only provides reduced cost services for like UNC facilities. And so it's something that's specific to our community and what's accessible around here. There's also a Duke financial assistance. So like some university hospitals are going to be able to offer things like this. It's not always the case, but yeah, UNC has this program called financial assistance. And what it is it's a program for patrons of UNC services. It is not insurance. This is a big point. It is not an insurance plan, but it operates as coverage and provides access to services otherwise unavailable. And this is because what it does is it reduces costs to this list here that you see, this list of co-payments here. So what we talked about earlier, the way insurance plans through the marketplace, all of that terminology that we discussed, a lot of it isn't relevant here anymore. There is no premium with financial assistance. There is no deductible with financial assistance. It's not an insurance plan. What it is a program that helps reduce costs for individuals by bringing down various services to these co-payments listed here. And then there's obviously, it's not just this list. There is an entire summary of all of the financial assistance benefits that you receive on their website, and we'll kind of get into that a little bit. But that's basically the way it works, is it brings it down to these fixed co-payments instead of the normal like large bill that you'd pay for like an outpatient surgery. So it's really an amazing program for people that otherwise wouldn't qualify for anything else. And we're going to get into the eligibility criteria for it. So like everything we've talked about, there is an income limit for financial assistance based off of both how much you're bringing in as well as how many people that's providing for, so your family size and your household income. And again, this is something that changes by year. So we have like a binder in the clinic that always has, or at least we always try to make sure it has the most updated numbers and information for all of these programs. So for UNC Financial Assistance, this chart you'll be able to reference and basically assess. Oh, you have the binder. Perfect. Perfect.
Have a date.
Yeah.
But yeah, we have a binder. You want to just let me pass it to you?
Yeah.
This is the one that I stole from you. It's okay.
We got through. Okay. So yeah, let me show you guys this here. So this is like an info sheet about us, but basically we have the tabs separated based off of what information you need to reference. So right now we're talking about UNC financial assistance. And if you were needing to like screen someone to make sure that they meet the eligibility guidelines, and everything in here is in both English and Spanish, since like I said, we deal with a lot of Spanish speaking patients. You would turn here. Okay, and then we have a binder copy of what you see here. So the eligibility guidelines for financial assistance. And then it's actually here, it's saying an income limit of 30,000.
That one's also.
This one's out of date too. Yeah, I figured because I don't think it would be lower. Oh, sorry. 36,450. I think that's the up-to-date one. Yeah. So yeah, there's like this information sheet that we always give patients every time we're counseling on financial assistance, as well as the application itself can also be found in here. But yeah, these are the income limits. I think we've talked about this, how to assess this multiple times at this point today, but that is one aspect of eligibility. The other aspect of eligibility is North Carolina residency. So pretty much to qualify for financial assistance, the only eligibility criteria you need to meet is to fall under one of these income limits, okay? And to be a North Carolina resident. North Carolina resident means you don't need to be legally residing in the US. You can be completely undocumented and apply for financial assistance. That's where this program becomes really, really beneficial. That's not the only situation, because there are other cases where this is also pretty much the only option, but especially for people that can't apply for anything that we talked about today because of documentation status, financial assistance becomes a really good option because they just need to be living in North Carolina and provide proof of that. I don't know if we talk about this in a section later, but I think it ties really well into what we were just discussing, which is approaching those conversations about documentation. You're going to have to do that a lot. So you need to make sure that whenever you're asking people anything about citizenship, documentation status, you're being very sensitive about how you word that question and how you discuss that, because it's very easy to assume from their end that they wouldn't want to share that information, because usually there's a stigma around it. Obviously, they might think there are actually consequences to sharing that information with us. So whenever you are asking questions like that, I always make sure I preface by saying, this is just so that I can know how I can best help you. This has no bearing on anything outside of the conversation that we're having. And I found that like being really clear about that just makes them feel more comfortable moving forward and talking about things like immigration status and stuff like that. I don't know if you have anything to add about that.
Well, you were actually just telling us that with Medicaid specifically, even if someone is working with the Medicaid department, they are not legally allowed to report to ICE.
Exactly.
So there's not gonna be kind of overlapping conversations. Obviously, things happen and like, we don't wanna completely promise like nothing will absolutely happen, but we wanna do all that we can on our part
Yeah.
to protect our patients.
Yeah. And I mean, I think we can say pretty definitely when it comes to submitting documents to financial assistance, that's not going anywhere outside of UNC. And it's just being used to assess eligibility for this program. So you want to make sure they're not like actively concerned about sharing that information whenever they're applying to this.
They could also be actively concerned about it.
Yes,
We had a
yes,
client
yes.
Who was working on a financial assistance application and just felt like, this is just too many pieces of information. I just don't feel like my privacy is being protected with this, so I'd rather stop.
Mhm.
You stopped, and we respected that decision.
Exactly. Yeah.
Do you have a question?
Okay. I'm seeing if this. I'm going to skip over the purple box, but okay, we'll keep going. Yes, that's what I was about to have them pull up. Yeah, could you guys go look up UNC Financial Assistance on Google? The first link that comes up will be, you guessed it, UNC Financial Assistance. So click on that. And I just want you guys to browse that, peruse the website real quick, and see what's there before I dive into like these steps.
Talk with each other about it.
If someone says like, no, information, allowed to be very, hey, this is not going in there.
You can, I mean, maybe what I would say is are there any concerns that you would like to bring up or any questions that you'd like to get answered for you?
Mhm.
I probably wouldn't assume like, hey, just want to remind you, this is not going because I feel like that can sound a little pushy. But you can be like, absolutely, we completely respect that. I totally understand where you're coming from. Just before we kind of close this conversation, are there any questions I can answer for you about where this information will go? Or, what the protections are?
And then I always too, like, with the patient Zara was just talking about when they said they expressed that privacy concern, I still said like, here's the link, to the website in case you do want to revisit this in the future and consider applying again. That way they have that in their own toolbox of resources, even if they don't necessarily want us directly helping them. So there are ways to, still be helpful without pushing too much, because we never want to be providing a service that isn't wanted,
You can also, you can also offer other things. Like it doesn't have to be Medicaid or Medicare or Marketplace or financial assistance. We're gonna talk about Piedmont Health Clinic and Sliding Scale clinics.
Mhm.
Like maybe you can pivot to something else that doesn't really, like, you can be creative and think, okay, well, this person's concern is privacy. What are some options that will still meet their financial needs, that is more protective of their privacy? And then maybe you'll shift there.
Exactly. Okay. So are you guys seeing on the website, the application? Oh yeah, let's do that. Okay, so there's a lot here. They actually redesigned this website, so I'm still like learning to navigate it. But There are multiple ways to apply for financial assistance. And the way that we usually talk about this in clinic is once we decide that they want extra support from us, then I'm like, is this something that you want to submit on your own, or would you like our support in getting that application sent to financial assistance for you? I'd say 9 times out of 10, actually 9.99 times out of 10, it's the latter. They usually want us to just go ahead and submit the application for them, just because it's, easier, and we can have that direct line of communication with financial assistance from that point. And in that case, that's something that we do outside from the clinic. We like fax over stuff directly to this office, and we'll teach you how to do that whenever you come in clinic. But here you can see all of the eligibility income requirements that we just talked about, and you can see the 2 things we said. So these are literally the 2 eligibility criteria. 1, are you a North Carolina resident? And 2, for your family size, does your income fall below this limit? Oh, yes, and that's big. Yeah, thank you for saying that. So you also can't be eligible for Medicaid, which we briefly mentioned earlier. These are not, you can't have both at the same time. So I'm going to really quickly pull up this application, which again, this is also, everything here is also in Spanish. And I'm going to show you guys what they have to submit in order to apply for financial assistance. So first, like we just said, you have to be screened for Medicaid, so that whenever they see your application, they know to assume that this is not something that you can go apply for instead. This is now something that like we can do without problems. Yeah, which is, I did use it for someone. Yeah, in clinic. Yeah.
It's out.
Yeah.
That will.
They're printed now in the Med Clinic binder.
Not there in the med finder, that we can do the Medicaid screen. But if-
Yes. So yeah, you just ask all of the main Medicaid eligibility requirements, fill that out on there, attach it to the application so that they now know this isn't something that they're eligible for. And then you have to provide proof of North Carolina residency. Do you guys know what that normally looks like, proving state residency, what type of documents that usually includes? Like, yeah, an electricity bill is a perfect example. Anything basically that has their name and their address on it. And the address that is also on the application. That has been a problem in the past. It was. I don't see why not. Yeah, I think, that would be fine. Just anything that proves that you live in North Carolina. So that could be a dorm, that could be anything. Yes.
If you provided your like something for your dorm and your second proof is your license, those are probably not matched because a lot of us are licensed to match our dorm address.
Yeah, that's what I was just about to say.
Like all of the addresses have to match.
All the addresses have to match is a big thing because there have been situations where a patient will come in with proofs of North Carolina residency, but they've changed address at some point. They need 2 proofs that you live at your current place of residence. So if your driver's license, you want to use that as your proof of residency, that needs to be the address that is on your application. So something to keep in mind. Income, the way that they actually make sure that you fall under that income threshold is in a couple of ways. But firstly, you have to provide the most recent 30 days of gross income, and that's can look like pay stubs. If you're self-employed, there's a self-employment verification form that you have to fill out. If you don't have any income, this can also look like a letter of support from whoever does provide you with financial support saying, this is how much I give them each month. And like them signing off and supporting them like that. So the income proof can look a few different ways. And then assets, this just applies to people that have assets outside of their primary residence. Very rare case that I've personally never dealt with. What was that? Oh, yeah. How do here. Yeah. Assets. Yeah, this is, things outside of your primary residence. Or sorry, the property is outside of the primary residence. Assets is, this is a new actually bullet that they added. It's not new outside of what they need to know, but a new bullet.
Yeah, it's just structured in a weird way that we are not used to, but
Yeah.
this is the bank statement one. So we have to collect bank
Yeah.
statements from from the person who's applying, and it needs to be from every bank that every account that they have open.
Mhm.
And that can be tricky because we've had it in the past where someone had an account that they didn't even realize was still open and had $5 in it, and financial assistance found that account and sent their application back and they had to do it all over again. So, just really stressing the community, all bank accounts they have,
Yeah.
including all of these things, a GoFundMe account. Venmo, apparently, I think you can keep money there. I know I had someone work with Venmo, PayPal maybe, I don't know. People use different things for banks, so anything that has, money in it. to
Mhm.
Be collected, and we try to do 2 months of statements.
Yeah, just to be on the safe side. So yeah, that's your bank accounts. On the previous one, it wasn't called assets. That's why that was throwing me off. This is like a new application, but anyways, yeah, you need to, yeah, like 2 weeks old. You also have to provide your tax return for the most recent year. Something that comes up sometimes is I didn't apply last year, but I applied the year, or I didn't file taxes last year, but I filed the year before. You wouldn't need to submit in that case. It's just for the most recent year. And this is something for both bank statements and tax returns. You only need to submit that if you have those things. So if you don't file taxes, you don't need to submit tax returns. If you don't have a bank account, you don't need to submit bank statements. But that's when it becomes really important to make sure that the pay stub information is really thorough, so that financial assistance still doesn't have any remaining questions. And then this is important. If you don't file taxes, that's usually where they're able to see who are your legal dependents, which again is really important because when we go to the eligibility chart that we were looking at, household size is a key determining factor for seeing if you qualify. So if you don't file taxes, but you need to prove that you have dependents, then in place of the tax returns, you submit the birth certificates of your dependents. And same thing where if you have a spouse and you need them to know that that spouse is part of your household, you would submit a marriage certificate. So yeah, those are all nuances that obviously you don't need to memorize right now, but they're definitely going to come up in clinic. So you'll run into it later. And then there's the actual physical application itself. So this is what we'll fill out with the patient when they're in clinic. And then we'll have them go collect those documents and then follow up with them when it comes to actually submitting. So that's UNC financial assistance application. Where is this? Oh, here it is. So the actual steps that it takes to make sure they are well informed on the program and then like supporting them in in the application is first step one, of course, introduce the program, explain why you believe it may be a good fit. This is also the time where you should be like, this is not health insurance. This is just health coverage, a way to reduce your costs, but this isn't an insurance plan. It's really important to describe that. And then of course, give the information summary. You should never just tell a patient about financial assistance, get them ready with the application, and then they leave without any information to reference on the program. That's why we have the summary sheets in the binder. So always share that with them. And this is a really helpful tip. And this ties into just asking about normal, like in the beginning of your conversation, you should always say, what's your experience with health coverage in the past? Have you applied for anything? But with financial assistance, especially, you should ask if they've applied for that before, because this can give you a really good indication of where to go from here. I've definitely had conversation where it's like, yeah, I applied for this in the past. I got denied or something, but I wasn't sure what documents I needed to provide again, things like that. And so then we can like better understand how we need to support them moving forward. So yeah, those are some helpful tips for that. If your client, after giving them information and everything, shows interest in the program, you offer, a plan to start the application. You only provide support in that application process if they, want that support. So ask them, do you want my support in completing this application and getting it submitted? And then if they do want your support, then you keep going. You go through the documents that the client will need to bring you or send to you. And then make sure that they have a really clear action plan for how to get going with that application. Yeah. So this is a big helpful tip. At the med clinic especially, our time can be limited with the client for various reasons. Some of them are the ones Zara mentioned earlier, like they've already been there for a long time and they want to leave, or there just simply isn't enough time to like go through everything. In those situations, that's why we have follow-ups, and that's why we follow up with our patients so that we can have that continuity with them and make sure that not only are we giving them information, but if that they requested our support, that we're actually following through with them. So decide what kind of time you have for the application depending on where the client is with their med team visit, and then make the plan based off of that. So you can always, like it says here, you can always move on to the follow-up step after considering how much time you have. So being like, hey, we can talk about this more thoroughly whenever you bring in XYZ documents next week, and we can get the application finally together and things like that. So not everything has to be done in one sitting. Rarely does, actually never does that happen, to be honest. Everything is based on follow-ups and making sure that a good plan is set out for the future weeks. So this is what we've already talked about. The completed application includes the written application I showed you, proofs of residency, bank statements, pay stubs, and tax returns. Yeah. And then before I move on to like the more about the follow-up plan, what questions do you guys have right now about financial assistance? That can be eligibility, document requirements, how to talk about financial assistance, anything. Okay. Yeah, so this is what I just said, create a plan for follow-up. So as you can see, okay. So point 2 here, determine who will be responsible for the client, is something that you're going to decide at clinic when you're there. After, usually it's a team of 2 going into each room, and after you guys have that interaction, you'll decide who's going to follow up with that client. And once you make that decision, you will put it in the note that we'll show you guys how to fill out whenever you're there in person, and then make a plan for follow-up. And so this can look a few different ways. So it can mean maybe they're coming in next Wednesday because they think that they can collect their documents in that amount of time. Maybe it's a follow-up call that you scheduled with them and say, hey, I'm going to check in with you on this day to see if you have any questions collecting documents and things like that. So you can kind of make a follow-up plan with your team member based off the conversation to see where you guys will be at in future weeks and things like that. Let me read through these tips real quick. Yeah. And all of our follow-ups, we also do schedule in the same EHR that we were talking about earlier called Practice Fusion. So if you decide with the client that they want to come in next Wednesday to bring in all of their documents to clinic, you would make a follow-up appointment on the Practice Fusion website so that it's documented there. But yeah, that's kind of broadly what the follow-up process looks like. And I hesitate to go too much into it because it really depends on the patient, and you'll get a better idea of how to make a good follow-up plan when you're in clinic and see what that looks like based off the conversation that you have with them. But do you guys have any questions about following up with patients right now, or the expectations about following up with patients? Okay. Oh, this is not, yeah. Okay. This one, okay, we'll answer hopefully some of your questions about following up. So making sure you have a plan is of course really important. This is a plan that you're going to set out before you leave clinic. That's really key. So that not only you have a good understanding of like action items, but so that the patient is leaving with a good understanding of action items, so that they know XYZ documents are what you need to come back with, or, we're going to be meeting in person at the clinic versus I'm going to call you. They should know exactly what to expect from you and your support. So that's really important. We expect our volunteers to write really thorough charts and notes. And this is because, like Zara was saying, we're a big group. And because of that, there's going to be times where our volunteers have to reference other volunteers' notes. We're going to come across a patient that maybe one of us have already seen or something. And in those situations, we want to be able to rely on the notes that we're writing and use that to refer back to. And we can't do that unless they're really detailed. So definitely make sure that we have like note templates for you guys to fill out, but just, go into clinic with a plan to be really thorough with that. And honestly, the note writing is something that you guys will start doing pretty much in the beginning with the new volunteers. Like I get them like writing this stuff pretty early on because it's a skill that you definitely have to build to make sure you're being thorough with that. And make sure to keep your word and follow up. this is really big. Like I really try to emphasize to volunteers, don't make a follow-up plan with a patient if you're not going to be able to follow up with that patient. So if you are noticing, okay, I have too many people to deal with right now, I can't follow up with them all at once. The way you should handle that isn't by not following up with them. You should come to one of us and say, hey, I need some support. And if we could maybe transfer this case to a different volunteer, that would be great, or something like that. But we don't want to leave people hanging and say, I'm going to call you next Tuesday to see your progress if we're not going to call them. And that's really, really important. I don't know if you had something to
I
add.
was just gonna say, it's a big responsibility, and I hope you all are excited about that, but it is actually a really big responsibility to be part of GCC and to work with patients and be part of their healthcare journey in this way. So take it really seriously. And I think that you'll be successful if you kind of have that mindset that I'm gonna do everything I possibly can
Yeah.
to support them.
And have the mindset that none of this is getting, most of this is going to need continuous support. So if they're coming in, wanting support from you, then they should expect that support they can expect that support to continue outside of the one encounter you're having if you say that it will. So it's really about follow through and making sure that you're not giving the patient a false sense of what they can actually receive when it comes to working with GCC. So yeah.
That's gonna help you out.
Yeah, that'd be great.
Alrighty, so we're kind of wrapping up a little bit here now, and we want to just remind you all that positive client interactions is the key. There's no step-by-step approach to patient interactions. We've given you some guidelines. We've given you like a starting place. I bet you're super overwhelmed with information, which is okay. That's an okay place to be right now. And as you get into clinic, it'll start to really make sense, and you'll start to apply it and continue to learn. We highlight this so often because it just needs to be said over and over again. That's okay, but I would love for you all to just kind of really take it in that it is so important. It's such a small thing to sit down next to your client instead of standing up over them. And you can sit down on the stool in the room if you're in med clinic. You can sit on the table if someone's sitting on the stool. You can sit on the chair next to the client. You can even kneel, right? I'm so sorry if you are like me and your knees start to hurt at some point, you're like fidgeting, like, make the best of it. Don't hurt yourself, but definitely as much as you can, it's so important to be at their level and not standing over people. But if you do have to be standing, then the better practice is to stand at a further distance. So it doesn't feel like you're towering over. So you would stand a little bit at a further distance, which is a really common thing that happens at dental clinic when you're speaking to people, because you are going to be in the lobby where they're seated, and you're often not. Usually that means I find a seat next to them and I'm like, so I think I take a seat right here. Hi, my name is, and I start talking to them. Or maybe I'll take a kneel. Or if there's just nowhere I can sit or stand, and I'll stand at a distance, like this space. And then lastly, approaching every interaction with empathy, attentiveness, and interest. Individualized care, we talked so much about this and how there are so many different factors and reasons it's considerations basically when it comes to helping a patient with their care. Careful listening, such an important skill. Autonomy for the patient. Does anyone have anything else that they want to add that we should strive for in patient interactions? I want at least one more answer. I think we're getting really sleepy, which is okay, but one more answer. Yeah. Yeah, like spending enough time to really understand what they're here for and not assuming. I love that. Did you have something, Thembi? Humility, absolutely. That should be on the list. Mhm. Anything else? Yeah. Positive tone or attitude, yes. Oh my gosh. It is Wednesday evening that clinic happens. Is anyone else doing anything on Wednesdays? Yeah, we have lives outside of GCC. Oh, right. Okay, so you're gonna be tired when you get to clinic. Everyone's tired when they get to clinic, but you push through. You're positive with your patients. They have had a life outside of getting to clinic. They probably had a full day ahead of them. Positivity, yes. And then sometimes the conversation that you have does not call for a joyous, cheerful tone, right? So it's about reading the room and being situationally aware too. Okay, what else? Anything else? Okay, great. Let's skip over this. So we really do try to aim for a holistic care of our patients. And these are just some examples of questions that you can ask. I know when we did those 3 scenarios and we broke out into groups, you all were coming up with the questions that we were missing and the things that we need to ask. So here are some examples. Do you have any existing health conditions that you're hoping to cover? Are there any chronic conditions in your family history? How often do you see the doctor? Are you currently taking any medications that we need to make sure we're considering? Anything that you're unable to afford or is not reliable in your current financial situation? When was the last time you saw a dentist? Are you currently connected with a dentist? Are you interested in learning more about our Shack Dental program? For vision, do you wear contacts or glasses? When was the last time you had your vision checked? Are you interested in learning more about our ophthalmology department in Shack? Right? So all this to say, we actually do a little bit more than healthcare or health coverage. And we really try to broadly look at people's needs. And yeah, we mentioned we have a social needs department, which their whole focus is asking about the social determinants of health and providing resources. But we have a very different way of working with our patients. We are more continuous, we have follow through. So I think it's important to still address these things, even if it's getting addressed with social needs, okay? Because they see social needs once and they're gonna see us quite often usually. Yeah, I mean, I don't need to read through all these resources, but there are so many resources. You're gonna start to learn them. I think it's a good idea to check out these slides. Yeah.
Show on Teams.
Oh, yeah.
Will be added to like the patient resources folder.
Yeah, that's a good idea. Let's do that instead.
I made reference to it.
Yeah. Are you signed into Teams already?
Yeah, I should, or on the app, on the app.
Oh, okay. Okay. Amazing. Okay. So, so on on the Teams website, which you all will be you all will get added to, there's a weekly operations tab and you're going to want to unhide. I think it'll say, what does it say? It's like hidden channels. And then you want to say show, right? And you'll do that for GCC once you get added to the Shack Med Clinic weekly operations so that you can see Get Covered Carolina. And you'll also want to do that for the general tab so that you have general information, but those are really the only 2 you need. We have a few others added. Feel free to join anything else you want to, but there's really no reason. Get Covered is going to be the one you use the most. And sometimes we'll post things. So like, for example, this new dental referral list form is an important thing to know about. Sometimes people will post if they're going to be out and they need a replacement or if we have spots for a clinic. So check out the posts. I would keep your notifications on. I have Teams on my phone too. You don't have to have it, but just a way for you to check this every so often, not every day by any means, but just keep an eye on it. And then in our files, we have a volunteer sign up. So this is what it looks like. And we release our slots every month. And you can see right here. So these are the people for like the end of February and March. And so we have a few spots open here where people are going to fill in. Okay. And there's a coordinator every night. And we have all these tabs at the bottom for all the clinic options that we have. So you all will fill out which clinics you want to be part of. We'll also ask you to put your name on the volunteer contact so people can text you if they need to get in touch with you. And then beyond the sign up sheet is all of these resources that we have. And the main one that you really need to get familiar with is going to be the patient resources folder. And this has a ton of different stuff. Actually, we just onboarded a few new leadership people. And so I think a project at some point will be to help us work on some of these resources, make them more robust and keep organizing them so they are more useful for you all in clinic. So you can kind of check out what these look like. Financial assistance, we have lots of different things under here. We have tabs for, let's see, where's dental? So for dental, we have a dental resources list. And actually the Spanish interpreter at the dental clinic, we had some time last time and needed to do this for a patient. She translated this whole thing into Spanish. So now we have a Spanish copy. Yeah. So now we have a Spanish copy of that as well. And then we also have lists for other different types of resources and just kind of like information databases. We're just trying to collect as much as we can, right? So you can feel free to add things here too. If you find something super helpful, you're like, oh my God, what are Verena and Zara doing? Why didn't we have this resource on our list in the first place? You can add it to the teams too. It's going to be a living space for us to keep learning together. Okay, I think that's good on the teams. Med Clinic is hosted at the Piedmont Clinic. So in the daytime, Piedmont is a sliding scale clinic. And then in the evenings on Wednesdays, it is Shack, but it is the exact same location. Okay. Sliding scale means, if I go back here, sliding scale clinics are clinics that adjust the cost of the services to your income. So that's another resource that you should not forget about when you're working with clients. It could be something really helpful to tide them over, or, be their continuous care that they need. We love Shack. All three of us have been part of Shack for a long time, including Dorian and Megan. I think all of us are like at least 2 years now, right? So we absolutely love Shack, but we strongly believe as GCC that our patients need to move out of Shack. Shack is a student-run clinic. There are not enough resources for patients. It is not always a very patient-centered approach, which is some of the qualms that we have about it. It's a learning environment, which should never be the priority over patient care. So there are things that we feel about Shack that give us passion to keep helping our patients find more continuous, reliable care, right? And we hope you kind of buy into that too.
Yeah, and like Shack as a whole shares that sentiment. Like,
Yes.
There's an entire program called Bridge to Care,
Yeah.
whose whole purpose is to make sure that they are bridged to other like long-term care. So that's like the whole idea of Shack is to provide that support that's needed right
Mhm.
now, but to make sure that we can connect them with
Yeah.
more long-term resources.
Yeah, our previous CEO was big on that. She was like, honestly, one day I'd love Shack to be obsolete. So yeah, we have other clinics. You'll learn about them. I mean, the knowledge can keep coming today, but I think we'll kind of wrap up. We have a dental clinic. This is what it looks like. It's across the street at the dental school. CEF is just on Rosemary, off of Rosemary, on MLK. So easy to get to on the bus route. Megan also is happy to pick up anyone, which actually we will always be happy to pick up anyone, give anyone rides. We know that it's sometimes hard to get off campus, especially with this clinic being in Carborough. We are always happy to give rides.
Don't be-
You're kind of like part of the GCC family now, so just kind of, it's okay to text us. I know people feel bad about texting me. I'm like, don't feel bad about texting me. It's probably better to get a text out to me than an email, and I don't know how you feel about that.
feel the same.
Yeah,
Yeah, text me, call me, whatever.
Yep. you can call for sure. Yeah, I'll probably call you because I hate, sometimes I'm like, I don't want to text all this out. I'm gonna just call you. Okay, we'll talk about practice fusion when you get into clinic. We won't worry about that. And then there's all of these tools that you have learned today. My gosh, you should be really proud of yourself. Give yourself a pat on the back. You learned a lot today, especially if you haven't gotten through your modules yet, or you haven't even gotten to get started, then you really packed a lot in today. So we are really proud of you all. And I would like you to take some time to reflect. I know reflection is like, blah, no one likes to do that, right? Please take some time when you go home or tomorrow and go through your notes again, see what questions you have. Come prepared to your first clinic once you're able to sign up. Transparency, it might not be for a month or so because we just got our last signups out and it looks pretty full. But we always say if you want to get into clinic, we are going to try to get you into clinic. So if you text one of us and you're like, hey, I really want to get into clinic this week, these are the days that work for me. Is there any possible availability? We will at least keep you in mind. If we already know there's a spot, we will replace you. And if it's possible, we will add another person. We'll add a slot for you to get in. And then the other things we do is sometimes if we have some of our returning volunteers who are signed up for a few more spots, we'll ask them to move out. So they'll give you some room. Okay. But it is tight is what I've heard to get into clinic. It can be difficult. So just be on top of those emails when we send them out to sign up. And then of course, if you don't get signed up, that's okay. You can email us too. Business casual. Oh, so important. Please dress.
Versus make me laugh so hard.
Yeah, I don't know who put this. Did I put this picture in? I don't know.
I put it-
Oh, okay.
Oh, it's so funny. I think that-
So bring your red purse. Otherwise, it's not a business casual outfit. Maybe it was like, how do you style this one red purse? 5 different ways. You don't need to bring a purse, but you can bring a backpack. You should bring a laptop. You should bring a pen. You should bring your devices charged, including your phone. This is the place that we will say, have your phone out with you because we need to communicate with you and you're going to be put in group me's. Be in business casual. And I know that's difficult sometimes as college students, but if you just have one pair of clean slacks that are not
jeans, and a shirt with a collar or even a nice sweater is fine with the colder weather. And closed-toed shoes is preferred. Okay. And if you have questions about that, you can always ask. And you'll get a vibe of like how we dress in the clinic, but definitely no shorts, no t-shirts, not what I'm wearing. This will not fly. Usually I'm dressed in, no. Yeah. Annika was making fun of me. She's like, I've never seen you in casual clothing because I'm always, this is the first day I can say, do not dress like me. Yeah. Okay. All right. So,
Go over, like, final logistics.
yes, please do that. Sorry, y'all, just give us like 5 more minutes.
Yeah, sorry, guys. This is important though. So the modules, I know some of you guys haven't finished those. If you have, that's great. But the modules, we do need you to complete those before you come into clinic. In order to be like a certified application counselor, you need to finish that certification and complete those modules. In addition to that, there's going to be a HIPAA certification that you need to complete. And we're going to need documentation of it. So we'll send you guys out a link to that afterwards. And then lastly, there's a expectations document that we have you fill out that basically lays out our volunteer expectations, and just so that they're very clear, and the expectations are clear, and then we'll add that to your files as well. Were there any other logistical things? I said HIPAA, finish your modules, and then expectations document that we're going to send out, but
Yeah. Yeah.
I heard you guys say something about like how Oxford troubleshooting.
yeah, or I mean, if you guys are available right now to briefly chat, like
We can
quickly.
do now, yeah, try again later. Well, we might do both because
Yeah.
we can talk right now and then get there, but like, talk about administrative burden, this process of you all getting into CMS is like, just stick with.
Yeah.
The challenges.
Yeah. No, and it will get done. It's just like, it's just red tape. Like sometimes, yeah, it's just going to take, you have to be really persistent with CMS sometimes.
Yeah, we had some people last time we trained and called who called so many times they got banned from calling.
Yeah, which is really funny. And yeah, some of you have probably already been given like 5 emails, none of which have like given you anything useful. So we'll talk to you each individually. If you do have like just a few minutes after we're done here to chat, and explain where you're at, then we can do that. And if there's still need for that afterwards, we'll definitely set up an office hour to chat with you guys. Any final questions or anything?
Please email us your questions.
Yeah.
The last part of this, I want you all to reflect and take time to think about everything process, okay? So you're not gonna get as much out of today if you don't do that, just a hint. But we're gonna celebrate everyone who completed their meeting today. So, Sanvi, congratulations. Clap for everyone. Neil, congratulations. Arissa, congratulations.
You guys are awesome.
CCC training, Meda. Sanvi, congratulations. Kendall.
You guys did that so quickly. Wow.
Yeah, this is a big props to our former marketing coordinator, now turned training. Putting it together.
In 2 seconds.
Congratulations, Lily Grace. Yeah, no classes. Jasmine's not here. Elise. Elise. Congratulations. Well done. Carson. And Frankie. Congratulations, everyone.
Woo! Great job. You guys should be very proud of yourselves for getting through today. So thank you for being here.
You all have a great rest of your weekend. We'll stay for questions.
Okay, let me stop recording real quick. 1 second. I just realized the people on the recording are going to be so confused about the flower in my hair.
No, they're gonna be like.
Yeah.
That's what I'm worried about. They're worried about-
Yeah.
Hey,
I'm gonna pick you up from your house at 6.